Hello friends, I'm Dr. Asma, your mentor this side. And today we are discussing the Green Top Guideline, which is about the recurrent miscarriages. This guideline is actually a new guideline which is published recently, and it is a Green Top Guideline number 17. It is released in June 2023. So actually this is a very important guideline, and many single best answer questions for MRCOG Part 2 students are coming from this guideline. And even in the part 3 as well, there is no exam in which any station from this guideline has never been taken. So this guideline is very important for MRCOG part 2 students and for part 3 students as well. I will try to make it as simpler as possible for you. And this guideline is actually full of a lot of information, and many recommendations have changed in this guideline. So it is very important to learn the new recommendations so that we can answer questions about it. Even apart from single best answer questions, many EMQs have also been made from this because it has a lot of information regarding investigations and the management of the recurrent miscarriages. In this discussion, I will be telling you in detail about what the new recommendations have been added in this guideline, and what further we need to do and how we have to read the guideline. Before proceeding with this guideline and its information, I just want to add one more information that when we are planning to read a guideline, any Green Top guideline, you know that it's quite tricky to read it. First of all, we have to go through the guideline, and we should be knowing that what important points are in this guideline which need our special attention, because otherwise there is no benefit of reading the guideline from page 1 to the last page, and we will not be retaining all the information. So it is very important that we should be knowing. So in this particular discussion, I will be telling you all the important points that you need to emphasize during reading this guideline. So that, and all the slides will be complete. After this discussion, you will not need to open the guideline again and then reading it again. These slides will be complete. It will be covering all the single best answer questions, and even for the part 3 students as well, it will be a quick revision for them. So let's start and let's go ahead that what about this guideline and what they are recommending now about the recurrent miscarriages. The recommendation for the definition of the miscarriage is same as it was in the previous guideline, and everyone is aware about the recurrent miscarriages, that what is exactly it is all about. In this guideline, they have given some other recommendations like ESHRE recommendations as well, but we are focused here in this particular session about the Royal College recommendations that we need for the MRCOG Part 2 and MRCOG Part 3 exams only, right? So I will be sharing only that information that is important for your exam point of view, and that is important in aspect of what the college want us to learn. So coming to the definition of the miscarriage. As all of you are already knowing, that miscarriage is the spontaneous loss of pregnancy from the time of conception until 24 weeks of gestation. So it means that pregnancy loss can be early pregnancy loss and it can be late pregnancy loss as well. So miscarriage include both pregnancy losses, early up till 12 weeks as well, and after 12 up to 24 weeks as well. So all the duration before 24 weeks will be included in miscarriage, right? This is all about miscarriage. It is a spontaneous loss. It means no intervention is being done. Patient is spontaneously losing the pregnancy, right? So that is a miscarriage. After the miscarriage, let's go ahead. They have actually, in this particular guideline, they have described the sporadic miscarriage and the recurrent miscarriage. As everyone knows that what is the sporadic miscarriage? Sporadic miscarriage is a miscarriage that happens spontaneously on itself, and it is usually common in the first trimesters, and fetal chromosomal anomalies are the most common causes of the sporadic miscarriage. And this new percentage has been added in this guideline, and this is the reason that I have mentioned in this slide. Because it was not mentioned in the previous guideline that the risk of sporadic miscarriage at the 20 years of age is 10, and at 45 years of age is 50%. Now, how we have to remember all these percentages? First of all, let me tell you, friends, that in part 2 exam, a lot of percentages are not going to come in your exams, but still there are some important percentages in few of the guidelines that you need to remember. But I am here to make it easier for you, and I will tell you that how we can remember them and how we can make it a part of our memory. Actually, if you can see that there is a 20 years of age, right? So at 20, the risk is half. What is the half of 20? It's 10. So at age of 20 years, what is the risk of sporadic miscarriage? It is 10%. I hope that it will become easy for you. And at 45 years, it's not going to half now. It's 45 plus 5 is equal to 50. So at 45, the risk of sporadic miscarriage is 50%. Everyone knows that as the advancing age, the risk of miscarriage is increases. So at 20 years, it's 10%. And at 45 years, it's 50%. Right? I hope it's clear. And this is the sporadic miscarriage. There are two types of miscarriages actually which has been discussed. Actually, the guideline is in detail about the recurrent miscarriage, but they have just mentioned the sporadic as well. And now recurrent miscarriage. What about the recurrent miscarriage? Actually, the miscarriage, the definition of the recurrent miscarriage is same as it was previously, like 3 or more consecutive miscarriages. Now, what is meant by 3 or more and then consecutive miscarriages? It means that one miscarriage, second miscarriage, third miscarriage. There is no alive, healthy pregnancy in between those miscarriages. 1, 2, 3. All 3 pregnancies which were in a sequence were miscarriages. These are 3 or more consecutive miscarriages, right? Now, actually, in the previous guideline, it was recommended that every management and all the management plan that we have to do for the patients will start after the 3 miscarriages. But now they have, in this guideline, they have discussed that they are encouraging all the clinicians that they use their clinical discretion as well to recommend the evaluation after the first 2 miscarriages if they're suspecting that patient is having some underlying pathology behind this mechanism that is going on. So they are expecting that clinicians can use their own clinical skills to justify the patients who need further management or investigations even after the 2 miscarriages as well, right? But the definition will remain the same. Definition will be 3 or more miscarriages and its implications will also be remain the same. Implications will not apply on the 2 miscarriages, right? Remember that for your question answers, for your single best answers and for your EMQs as well. And it is very, very important for the part 3 students as well. Because 100% 1 or 2 stations are coming from this guideline, or even many other stations as well in which this implication or the knowledge of this guideline will apply. So there is no chance of missing this guideline. Okay, so the most important incidence that we have to remember in this guideline is it's affecting 1% of the women. So what is the incidence of the recurrent miscarriage? It is 1%. So 1% is not difficult to remember, I think so. Recurrent, it's 1%. Then at 20 years, I have told you that half of the 20 is 10. It's 10%. It's sporadic miscarriage. At 45, we will add 5 and then it will become 50%. So this is a little bit introduction that they have given about the miscarriages. Now coming to the risk factors. Now, my friends, actually the risk factors, it's very now important to remember in this guideline because any single best answer question can come. And even when you are appearing in the part 3 at the time of communication with the patient, it is very important that you should be knowing what are the risk factors in this particular patient so that you can address those concerns only. And what risk factor is more important, what is less important, and you know that they have made a little bit changes as well. So as all of you are knowing that advancing maternal age, it increases the risk of miscarriage. So it is the same as it was previously. Now advancing paternal age, it increases the risk of miscarriages, although not as markedly as with the maternal age. It means maternal age is still a most important factor and paternal age is also a risk factor and it increases the risk of miscarriages, but not as markedly as maternal age, right? Now, the other risk factor is number of previous miscarriages. It increases the risk of subsequent miscarriages. Whenever there is any sort of miscarriage, any sporadic miscarriage or any other miscarriage, at that time, the risk of, in the next pregnancy, the risk of miscarriage is definitely increased. So the number of previous miscarriages increase, the risk of subsequent miscarriages is also increased. And previous live birth, definitely if there is a previous live birth, there is no association with the next miscarriage. Then black ethnic background, it also increases the risk of miscarriage. Why you ask in the history ethnicity? When you ask in the history ethnicity, then definitely what is in the back of your mind is that black ethnicity, the risk of miscarriage is increased. It is all mentioned in the table 1 of the Green Talk guideline. So it is very important to remember. And even in the single best answer, this question can come that they can mention many ethnicities in the options, and what you have to choose, black ethnic background. It increases actually the risk of miscarriages. Like many other conditions which increase the risk of other conditions like Caucasian ethnicity, there is certain risks are increased, and some Mediterranean ethnicities, the risks of further conditions are increased. Southeast Asians, polycystic ovarian syndrome is increased. So you know that with ethnicity, there is a lot of conditions are related. So here the black ethnic background, it actually increases the risk of miscarriage. Then consanguineous relationship, no increased risk of recurrent miscarriage. Consanguinity is not going to increase the risk of miscarriages. Smoking. Smoking, alcohol, and caffeine. Now you have to bundle it up. Just remember that these three risk factors, you have to combine these three, right? Because you're going to mention in a one go in part 3 as well, and for part 2 as well, you have to remember smoking, it increases the risk of miscarriage. Excessive alcohol consumption, it increases the risk of miscarriage. Excessive caffeine consumption, it also increases the risk of miscarriage. Now, among these three, what is the factor which basically increase the risk of miscarriage? Among these three, alcohol increases the risk of miscarriage markedly. And this is a very important that you have to remember. It can come in a single best answer question, right? And then this guideline also address about BMI, right? What is the optimum BMI? That is important, and that we need to remember. BMI of less than 19 and BMI of more than 25, it increases the risk of recurrent miscarriage. So it is very important that we have to tell the patient that the BMI should be optimized to reduce the risk of miscarriage. It will come later on in this management options. And then the environmental chemical exposure and the dietary intake. It further increases the risk of miscarriages, but there is a lot of studies which are more required and further information is needed. Now this slide is very important, friends. Let me tell you that why it is important. Although it appears that there is a lot of numbers mentioned over here and a lot of ages have been mentioned, but let me tell you that actually it's a frequently coming questions in the exam. In MRCOG Part 2, in every practice book, these percentages have been mentioned. In the recall questions, these percentages have been mentioned. In the strategy questions, in the past MRCOG, lot of questions have been from this guideline, and this slide is very, very important. Now I will try to make it easy for you so that you can remember it. First of all, before trying to memorize all of these numbers, you have to see that what is the exact age which is associated with the least risk of miscarriage, right? What is the appropriate age when you are, even in your general consultation, when you're discussing with the patients, what is the age which is associated with the least risk of miscarriages? It is 20 to 24 years. Now this is, you have picked up this thing that this is 20 to 24 years. It is associated with 11% risk of miscarriage, right? Now forget all these numbers. 20 to 24 years, 11% risk of miscarriage. After 11, come to this point, 30 to 34 and 40 to 44. It is quite easy to remember. When someone reaches at the age of 30, everything started going to change. So 30 to 34, risk is 15%. When this patient reaches at 40 to 44 year, the risk is reversed. What is the opposite of 15? It is 51. You will take the 5 over here and 1 over here. This is 51, right? So 30 to 34 years, 51, and 40 to 44 years, 51. And this is 15, sorry. 30 to 34 years, 15%, and 40 to 44 years, 51%. So after this 10 years, then in this 10 years, the risk is reversed. 15 and 51, 15, 51, 15 and 51, right? 3 digits we have memorized. Okay, if you can follow me, what is the least risk of miscarriage? It is 11%, it is at 20 to 24. These all start from 20, 30, 40, right? These are at the alternate digits, 20, 30 and 40. 20 to 24, 11%, 30 to 34, 15%, 40 to 44, 51%. Now after 45, like this is a cutoff value, right? After 45, the chance of conceptions are also very less, and they are not going to discuss any reproductive issues after the age of 45 mostly. So at age of 45, the risk is the highest, and that is the number 93. 93 cannot come over here anytime. We cannot say that at 20 to 29 or 30s, the risk of miscarriage can be 93. Then it would be a disaster. So it means that extreme of ages, when she reached at the end of her reproductive years, 45, then the risk is 93. So how many numbers we have memorized? 1, 2, 3, and 4, right? Now you have to remember that this is 35 to 39, and it is in between these two, 15 and 51. It is also including 5 digit. So it is 25, and 12 to 19 years, 13%, which is among these 20s, this is the highest number, right? Teenage pregnancy, just remember that teenage pregnancy is associated with a maximum risk. So it is 13. It is not 11, it is not 12. When she will cross her teens, her risk will be reduced. So the teenage is associated with a maximum risk among this age group, before 30s, right? In the young age group. So 13 is a maximum. What is the least risk? 20 to 24. And what we are left with? 25 to 29, 12%. So I hope if you would revise this page, keeping all these things in mind, then it would be easier and it would last long in your memory as well. Even it will be very easy to remember in your exam as well, that yes, what ma'am has told us in teenagers, what she has told us in 40 to 45, 44, in the 30 to 34, just remember 30 and 40, 30, 40, 15, 51, 15, 51. Remember these in relationship to this. You always remember the things when they are in relationship with each other, right? That will be easy for you to remember. And just remember that you will make a list of this percentage from this guideline, and you will paste it on the walls, on your door, so that while coming in the door, while coming out of the door, you can just have a view of these pages, right? And that can be increase your memory differently. Yes. The most important factor which is responsible for this condition and which increases the risk of recurrent miscarriage is thrombophilia. Actually, I have brought it immediately because I need to discuss this thing very earliest as possible, because it is a very important slide. What does the thrombophilia means? Thrombophilia, definitely everyone knows that it means increased coagulability, increase the tendency to for the thrombus to form. So that is thrombophilias, and it means increased tendency for the clot formation, right? Now the increased tendency for the clot formation, this condition is called thrombophilias, right? These thrombophilias can be acquired. It means that they are not inherited. Patient has acquired it after they are born, right? And inherited. Inherited means that patient is born with a thrombophilia. Now this guideline actually revolve all around this. And let me tell you friends that in this slide, in this particular slide, single best answers are coming. This, and this. These are definitely coming. There's 100% chance of these questions are coming in a single best answer questions. And even EMQs. Many EMQs will be formed from its management plan. These will be coming in the next few slides. I will be showing you. So acquired antiphospholipid syndrome, acquired thrombophilia. What actually acquired thrombophilia we need to discuss in this particular guideline, that is antiphospholipid syndrome. Right? You all have guidelines in the hard copy, in the soft copy, and you can read it very well. But why I'm here to discuss this guideline, so that I can just make a complete picture in your mind, and when you will, if you want to go back and you can read this guideline, you will have a clear picture and you will be knowing that what point we need to pick from this guideline. So this is a very important point. Okay, let's start. So acquired thrombophilia, that is antiphospholipid syndrome. What is antiphospholipid syndrome actually? It has some clinical criteria and it has some lab criteria as well. So here they have mentioned the clinical criteria, that what is it all about. Antiphospholipid syndrome is an association between antiphospholipid antibodies. First of all, remember two things. Antibodies, and there is and in between, right? What are the antibodies? There are 3 types of antibodies. Antibodies and then and adverse pregnancy outcome. So it is a combination of 2 things. One is the antibody and other is adverse pregnancy outcome. Its combination is called as antiphospholipid syndrome. Now we will discuss in detail what about the antibodies, and we will also discuss the adverse pregnancy outcome. Okay, so what actually we have combined in antiphospholipid syndrome? Antibodies and adverse pregnancy outcome. This is the combination of these 2 things. What sort of antibodies we are going to discuss? Antibodies are actually of three types here, friends. That is the lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta 2 glycoprotein 1 antibodies, right? Lupus anticoagulant, anti-cardiolipin, anti-beta 2 glycoprotein 1 antibodies. These are the three antibodies which are included in antiphospholipid syndrome. And as I have mentioned, it's a combination. So, and adverse pregnancy outcome or vascular thrombosis, right? Vascular thrombosis means it's not related with pregnancy because it's a tendency to formation of the clot. So, the thrombus or the clot can form in any vessel of the patient, right? So, it can be any of these two. Here we are discussing as the recurrent miscarriages. So we will discuss about the adverse pregnancy outcome, that what we exactly mean about the adverse pregnancy outcome. What actually we call that adverse pregnancy outcome is 3 or more consecutive miscarriages before 10 weeks. Friends, remember there are 10 weeks, right? Now the consecutive miscarriages, and these will be 3 or more, right? And these should be before 10 weeks. 3 or more consecutive miscarriages before 10 weeks. In the recurrent miscarriage, it was not before 10 weeks, it was 24 weeks. Here, 3 or more consecutive miscarriages are before 10 weeks. Like I have already mentioned, that we remember the things in relation with each other. So, here in this definition, it is 10 weeks only, right? There is no 24 weeks. This is 10 weeks. So, 3 or more consecutive miscarriages before 10 weeks. Then, what the next adverse pregnancy outcome can be? 1 or more morphologically normal fetal loss after 10 weeks of gestation. Okay, it means that fetus was normal. There was no abnormality. That was not a syndromic baby. That was the normal baby, but the fetal loss happened after 10 weeks of the gestation, right? Intrauterine fetal demise happened after 10 weeks of gestation and the baby was fine. 1 or more preterm birth before 34 weeks because of placental disease. Now, this line is very important. Let me explain few things over here. First of all, what we call preterm birth is, normally we say that before 37 weeks it's a preterm birth, but here they have taken the cutoff of 34 weeks. So it is a very important to remember. 1 or more preterm birth that occur before 34 weeks. And why the preterm birth has happened? Why patient has gone into the preterm birth and the baby has born premature? Because of placental disease. What does the placental disease means? Placental disease means that there was some sort of vascular thrombosis in the vessels of placenta. And that is because of this autoimmune condition, which is producing antibodies and which is increasing the tendency to the clot formation. This is actually the pathophysiology behind it. And there is increased clot formation and the occlusion. When there is increased tendency to the clot formation, it is also called, when you will be in the MRCOG Part-3, students may be knowing that this is called sticky blood syndrome, right, in the layman language. So what the sticky blood syndrome means, that the blood becomes sticky. Therefore, there is a lot of coagulation or the thrombus or the clot formation in the vessels of the placenta. So the placental blood supply is blocked and the blood supply is unable to reach to the fetus. And this is the reason which is leading to all these adverse pregnancy outcomes. I hope I could make it clear. So this is all about that how antiphospholipid syndrome is causing all this condition. Now there is many single best answer questions that are new in this guideline, so they are definitely going to come. First of all, which antibody has strongest association with recurrent miscarriage? I have mentioned 3: lupus anticoagulant, anti-cardiolipin, anti-beta 2 glycoprotein 1 antibodies, right? Now, which one has the strongest association? Just remember like this, that the lupus can be the dangerous thing among any of these, right? Like lupus nephritis, systemic lupus erythematosus. So lupus means something which is dangerous. So lupus has the strongest association. I'm just trying to make things easier for you to remember on the exam day so that you will be knowing and you do not need to just cram it up and you have, it will be in your memory, right? That yes, ma'am has told that lupus is the most dangerous thing. So that is the strongest association. It is causing the adverse pregnancy outcome. It's a very bad antibody, right? It is not a good antibody. It is the worst antibody which is causing all these type of effects. So this is the strongest association. Okay, which antibody has second strongest association? Now, what we are left with, anti-cardiolipin antibodies, right? Anti-cardiolipin antibodies, it's IgG, it's IgM. Among any of these can be the most dangerous. But IgM is probably causing more harm, right? So after this, what we are left with actually, we are left with only one antibody, and that is anti-beta 2 glycoprotein 1 antibody, right? Anti-beta 2 glycoprotein 1 antibody, actually the evidence is less conclusive. IgG or IgM class in the high titer. So you know that it is less significant. And how we will clinically diagnose this. This is the clinical criteria. And what is the lab criteria actually? That I will be discussing in detail, and then the inherited thrombophilia. So it is not, its association is not statistically significant, right? It is sort of benign antibody. Its association has not been found, although it is a part of definition of antiphospholipid antibody syndrome, but it is the least harm. It is a harmless antibody. Okay, and then comes here. Yeah, we were here. Inherited thrombophilias. What sort of inherited thrombophilias? The famous inherited thrombophilias, which are very famous in obstetrics, are antiphospholipid, are antithrombin 3 deficiency, factor 5 Leiden mutation, protein S deficiency. All these are actually have a weak association with a recurrent miscarriage. So it means that in this particular guideline, we are not going to discuss in detail about them, and it's also not going to influence the management of patient as well, right? Actually, antithrombin 3 deficiency is the rarer, yet it is most thrombogenic mutation. Everyone knows that inherited thrombophilias, antithrombin 3 is most dangerous or the most thrombogenic, but its association with a recurrent miscarriage is not been found. Maybe it can cause like factor 5 Leiden mutation, particularly they can cause first or particularly second trimester miscarriage as well, but the recurrent miscarriage means 3 or more consecutive miscarriage. In that case, their association is weak. Am I clear? Okay, all right. Now go ahead. Yes. Now we are going to discuss the genetic factors, that is parental chromosomal rearrangements, right? Actually, the miscarriage risk is increased and it depends upon the type of rearrangement as well. The parental chromosomal rearrangement is basically a genetic factor, and fetal chromosomal abnormalities as well. There are two types of genetic factors which are contributing. So the parental chromosomal rearrangement, it actually, in this guideline, they have mentioned that the parental chromosomal rearrangements, it increases the risk of miscarriages. It increases the risk of recurrent miscarriage, right? It increases the risk of miscarriage, but remember that all type of chromosomal rearrangements are not going to increase the same risk. Okay, so it depends upon the type of the rearrangement. Increases with reciprocal chromosomal rearrangement, reciprocal translocation, Robertsonian translocation, and inversions, right? So you have to remember these three names: reciprocal translocation, Robertsonian, and inversion. Robertsonian translocation, it actually increases the risk of almost 54%. Every percentage is not important to remember, but just to make it feel you like it is very important, I just want to tell you that reciprocal translocation, it increased the miscarriage rate 54%. And Robertsonian translocation, it increased the risk of 34%. 54 and 34. 54 and 34. And inversions increase the risk of miscarriage 49%. And others also come. But basically, the point important is to remember is that parental chromosomal rearrangements increases the risk of recurrent miscarriages. So it is a risk factor and it exists, right? Now we have to see the fetal chromosomal abnormalities, right? Actually, fetal chromosomal abnormalities is the commonest cause of sporadic and the recurrent miscarriage as well. When the single best answer will come that what is the commonest cause of sporadic miscarriage, what you will answer? Fetal chromosomal abnormalities. If single best answer question will come that what is the commonest cause of recurrent miscarriage, what which you are going to pick? Fetal chromosomal abnormality. There will be a lot of options will be given, like genetic problems, anatomical problems, and thrombophilias. Many things will be discussed, many things will be mentioned over there, but what you are going to choose? You will only choose fetal chromosomal abnormalities. For the recurrent miscarriage as well, and for the sporadic miscarriage, these are the two questions. One is this and one is this. This is another question. Okay, let me tell you first that what fetal chromosomal abnormalities we are suspecting that will increase the risk of recurrent miscarriage. Actually, they have already mentioned that it increases the risk of both sporadic and recurrent as well. Parental chromosomal rearrangement increases the risk of recurrent miscarriage, and fetal chromosome abnormalities increase sporadic and recurrent as well, right? So after actually, what is the chromosomal abnormality which increase the risk of miscarriage? It is, you have to remember only one name. It is trisomy, right? There are many other conditions like polyploidy, monosomy, structural anomalies, but remember only one name, that is trisomy. It increases the risk of recurrent miscarriage almost 51%. Okay. And the one more important thing, that miscarriage of euploid pregnancy loss. What does it mean? Euploid pregnancy loss means that there was no chromosomal problem in the miscarriage. It also increases the risk of subsequent miscarriage, because you know that with every passing miscarriage, the risk of further miscarriage in the subsequent pregnancy will be increased, right? I hope I could make it clear. Now here comes the anatomical factors. Anatomical factors are, they can also come in single best answer questions, and in even their management options, in the management of EMQs, when the EMQs will be made from the management option, they can pick up from the every factor. Like they will write the options above, and below they can write scenarios, 2 to 3 scenarios. One will be from anatomical factor, one will be from antiphospholipid syndrome, one will be from inherited thrombophilias, and you have to pick up from the options given above. So it is very important to remember that what actually is increasing the risk. Anatomical factors. Actually, congenital uterine anomalies increase the risk of miscarriages with septate and bicornuate uterus. You have to remember only these two names, septate and bicornuate. Septate means that there is a complete septum in the uterine cavity, right? This is the uterus, and in between there is a complete septum, that is the septate uterus. Now, what is the bicornuate uterus? In which there are two cornules, it is called a heart-shaped uterus, right? These are the congenital uterine anomalies. These increases the risk of miscarriages. What about the acquired uterine anomalies? Actually, it is uncertain due to some lack of studies, and you know that lack of data available. So it is uncertain that whether acquired uterine anomalies increase the risk of miscarriage or not, like myomas, fibroids, endometrial polyp, intrauterine adhesions, and cervical integrity. These have been discussed and these have been studied, but still evidence and the data is lacking to make any certain recommendation. So evidence remains uncertain as the lack of data. In endometrial polyp as well, there is no data. So same management as of general population. They are not recommending any particular management like removal of polyp or removal of myoma for any of these anomalies. So if any of this question will come, you are not going to choose the option that removes the myoma or do the myomectomy. You are not going to choose polypectomy. If they will say that patient is having miscarriage and she's having endometrial polyp, you're not going to choose that because there is no evidence. We are not going to change the management. Intrauterine adhesions, implication for the women undergoing surgical management of miscarriage. It has, like, adhesions have implications for those women in which we are going to plan the surgical management of miscarriage. And endometrial thickness less than 5 mm, higher is the risk of sporadic miscarriage, right? You have to remember this figure, that endometrial thickness less than 5 mm, the risk of sporadic miscarriage can be high, because definitely we need certain thickness of endometrium for the proper implantation and progression of the pregnancy. Now, the cervical integrity. You all know that cervical incompetence, it predisposed to the second trimester miscarriage, right? It is not the recurrent miscarriage. Okay. Yes, this is a very, very important slide, and there are many new things that they have added. And I'm 100% sure that these few things are coming in your exams because these are new. So definitely they are going to check that whether students are knowing this or not. Okay, so let's discuss them. Yes, risk factors. First of all, I will tell you the risk factor, and in the next coming slides, I will be telling you that how these are going to be managed, right? All these conditions. First of all, well-controlled diabetes and the thyroid disease. Everyone knows that when the medical disorders are well-controlled, then the risk is very less. So no increased risk of recurrent miscarriage when there is a well-controlled diabetes and the thyroid disease. It means that patient is well-controlled, diabetes is not deranged, thyroid hormone levels are not deranged, even if she is on medication or whatever sort of treatment she's taking, but the levels are well-controlled, then the risk of recurrent miscarriage will not be increased. What is this exactly? This is a subclinical hypothyroidism. This is the new thing that they have added, right? It means that thyroid levels are getting low, but patient is not having symptoms. Subclinical hypothyroidism, they have told in this guideline that it increases the risk of recurrent miscarriage, and I will be discussing this particular topic in detail in the next few slides. Now, thyroid autoantibodies, thyroid peroxidase antibodies, these are very important, increase the risk of miscarriage. Up till now, from the endocrine factors, what we have learned, that subclinical hypothyroidism and thyroid autoantibodies, they both increase the risk of recurrent miscarriages, right? Polycystic ovarian syndrome increase the risk of miscarriages, but that is not discussed in detail in this guideline, and any other management strategies has not yet been recommended. Prolactin imbalance increase the risk of recurrent miscarriage. Luteal phase defects. These have also, like luteal phase deficiency, progesterone deficiency, insufficient inconclusive evidence up till now. Okay, now coming to the investigations that we need to do for the patients who are having the recurrent miscarriages, because the EMQs will be planned and will be made from the investigations and from the treatment part. And for MRCOG Part 3 students, let me tell you that this exam station is definitely going to come. There is no exam in which pregnancy losses have not been discussed. And even more than one station can come in any form. Sometime they can put intrauterine demise inside that, sometime recurrent miscarriage, sometime patient is having previous losses and now they're coming with a healthy pregnancy. Like there can make a lot of combinations. Okay. So now we'll discuss this. Okay, to investigate the recurrent miscarriage, we are going to discuss the thrombophilias, right? Acquired thrombophilias, particularly for the lupus anticoagulant and anticardiolipin antibodies. And to diagnose the antiphospholipid syndrome, which we have already knowing that it is a basic cause of recurrent miscarriage, what we are going to do? We are going to do, to diagnose antiphospholipid syndrome, we will do 2 tests, right? These 2 tests will be at least 12 weeks apart. 2 blood tests will be done to check the antibody levels, and these will be 12 weeks apart. Okay, what is the half of 12? It is 6. So when this test will be performed, when these 2 tests will be performed, when patient is pregnant, when patient is having miscarriage, when patient is 6 weeks, 12 weeks, 13 weeks, 24 weeks, when these tests will be done? No, these tests will not be done in the pregnancy. These tests will be done 6 weeks post miscarriage. Just remember this number. This is a very important point, because in the part 3 exam, when the patient is coming with a scenario and you will be saying her that we are offering you test right now, these are not recommended right now, these will be done after 6 weeks post miscarriage, and this will come in the single best answer as well. That when we have to do this test, single week after 6 weeks of the post miscarriage. And what we are going to check? We are going to check lupus anticoagulant antibodies, anticardiolipin antibodies of IgG and IgM, and if these are present in the medium or the high titer, which means that more than 99th percentile. Anti-beta-2 glycoprotein antibodies, for which the evidence is less conclusive, as I have already told you that this is a benign, this is not a dangerous antibody. But we have to measure this as well. And if it is IgG or IgM in a high titer, more than 99th percentile, right? Okay. So, are we going to check the inherited thrombophilias for the patient or not? No. Actually, we are not going to test inherited thrombophilias for the recurrent miscarriages. Just mark my words, right? For the recurrent miscarriages, we are not going to assess the inherited thrombophilias. Women with the second trimester miscarriages, they can be offered testing for factor 5 leading mutation, prothrombin gene mutation, and protein S deficiency. Ideally, this should be done in the research context only, because the currently the limited evidence for the treatment, that the treatment of the inherited thrombophilia will be done, and that can change the reproductive outcome. There is less evidence. So we are not going to test. No testing is recommended for, right? There is less association. So we are not going to test inherited thrombophilia, mark a big cross over here. And we are going to check for the acquired thrombophilias. I hope I could make it clear. Now comes the genetic factors. Okay, so genetic factors, yes. The thing again has been changed in this guideline. To check the genetic factors, what we are going to do, what does the genetic factor mean? That I have already discussed, that the parental chromosomal abnormalities or the fetal chromosomal abnormalities, right? We are going to cytogenetic analysis should be offered on the pregnancy tissue of third miscarriage. It means in the scenario there has been given that patient is having 2 miscarriages already, and now she's pregnant and she is going to expel. Her miscarriage is being undertaken, and the miscarriage is being under the process, whether she is undergoing medical treatment of miscarriage, or the anything has been done for her, but this is the third time she is going to miscarry. At that time, what we are going to do, when the pregnancy tissue will be obtained, we are going to do the cytogenetic analysis for that tissue. Now, what new thing has been added? First of all, this is the criteria for the cytogenetic analysis. What is the first criteria? Pregnancy tissue of third miscarriage, right? First miscarriage has been done, no need of cytogenetic analysis. Second miscarriage has been done, no need of cytogenetic analysis. Now, third time she's going to miscarry. Now you will not discard the pregnancy tissue and you will send that for the cytogenetic analysis. Now, the other thing, the new thing that they have added in this guideline is that any second trimester miscarriage, we will not send the patient who is having second trimester miscarriage even at the first time. This is the first time she's having miscarriage, but that is after 12 weeks of the pregnancy. This is her first miscarriage, right? But we are not going to send her back without cytogenetic analysis. We will do cytogenetic analysis in the patient who came with us with a miscarriage and she is more than 12 weeks of the pregnancy. So this is her first miscarriage, but still we are going to do. So these are the two standards, so the two criteria for the cytogenetic analysis. If the tissue reports, now cytogenetic analysis has been done and she is back with us with a tissue report. What the tissue report has revealed? Unbalanced structural chromosomal abnormalities. There is some abnormality has been found on this tissue report that we have taken from the pregnancy tissue from the patient. Then what we are going to do? Then we are going to do parental karyotyping should be performed, right? Then we are going to do parental karyotyping. At the first instance, we are not going to check the parents. Parental karyotyping should not be checked. Parental karyotyping will be checked when this test will become abnormal. I hope I could make it clear. Now, one more thing that they have added. In the last guideline, there was no other reason to go for the parental karyotyping. This was the only one criteria, or this was the only one justification to do the parental karyotyping. Now they have added this thing that any second trimester miscarriage. Second thing they have added, if abnormal parental karyotyping found, referral to the clinical geneticist will be done. You all know that if in this parental karyotyping some abnormality have been found, then definitely we are going to refer the patient for the clinical geneticist. If no pregnancy tissue is available, then parental karyotyping should be offered. If pregnancy tissue has not been available, has not been successful, then parental karyotyping should be offered. This is another change in this guideline. Okay. Now we have discussed how we are going to diagnose the management, how we are going to diagnose antiphospholipid syndrome. Now to rule out the anatomical factors, what test they have recommended and what we have to pick in the question answers. Women with the recurrent miscarriage, they should be offered 3D ultrasound for the assessment of congenital uterine anomalies, right? Because detection rate of 3D ultrasound is quite high, that is 97%. And 3D ultrasound is recommended as a first line investigation. This can come as a single best answer questions. Friends, just remember, this is very important. And 3D ultrasound is recommended as a first line for the diagnosis of congenital abnormalities. Now they have reserved MRI and endoscopic evaluation for the complex anomalies when the diagnosis cannot be reached with the 3D ultrasound. It means when 3D ultrasound is not conclusive, right? Or when the 3D ultrasound is giving some findings and we need to elaborate it further, we need to dig it further that what is exactly the anomaly is, then we can do the MRI or the endoscopic evaluation for the complex anomalies. We have found some anomaly over here, then we will proceed with the further investigations, that is MRI and the endoscopic evaluation for the complex anomalies. Okay. Now the very important part of this guideline is coming, and that is the treatment part, right? Treatment part is very important in this guideline, and many EMQs will be made from this because this is a new thing in this. So definitely many EMQs can be made. Endocrine factors women with a recurrent miscarriage should be offered. Like we have already mentioned, thyroid and diabetes, when they're well controlled, they're not going to increase the risk, right? But with recurrent miscarriages, we're not going to do all other investigations. We will be offering thyroid function test and thyroid peroxidase antibody testing, right? So this is a very important thing. We are going to do TFTs, thyroid function test, and thyroid peroxidase antibodies. Why we are doing this? Because this has a significance. This increases the risk of recurrent miscarriages. This is the reason we are going to evaluate. And second reason for doing this test is that we have the management plan for this now. They have made the recommendations for this treatment. Okay, we will be discussing that treatment in the next few slides. Infective factors. Actually, for any infection to become a cause of recurrent miscarriage, it is important that it will be staying in the genital tract, it is asymptomatic, and it is not responding to any further treatment. Because if any infection in the genital tract, it will be symptomatic, then definitely patient is going to address that, and patient is going to the clinician, and he is going to give her medication, and the genital tract infection will be solved, or that will be completed, eradicated. So for the genital tract infection to be responsible for the recurrent miscarriage, it is important that it is not easily picked up and it is asymptomatic. So according to this guideline, there is insufficient evidence for association of the genital tract infection with the recurrent miscarriages. Infection screening is not recommended. This is the line that you have to remember. Infection screening is not recommended. You are not going to do TOT screenings. You are not going to screen any other infection in the patients because infective factors, they have insufficient evidence for the recurrent miscarriage. As I have told you that this is what is the rationale behind this recommendation. The rationale behind is that the infective factor, if they are responsible for the recurrent miscarriages, they can become obvious with their symptoms, and patient is going to the clinician and he's going to address her symptoms, and that is going to resolve. So that can cause one miscarriage or the other, but that cannot cause recurrent miscarriage. This is the reason that the infection screening is no more recommended, is not recommended. Male factors. Now, what male factors are actually responsible? Increase sperm DNA fragmentation, increase the risk of miscarriage, right? And but you know that they have not recommend any sperm DNA testing is not required, right? Data is more consistent with regard to association between abnormal sperm DNA parameters such as sperm DNA fragmentation, nuclear chromatin decondensation, and the sperm aneuploidies in the miscarriages. But actually, although it increased the risk of miscarriage, they have mentioned that male factor, as in the risk factors we have already discussed, that male factor is responsible for increased risk of miscarriage, right? But actually, DNA testing is not recommended. Limited studies are available evaluating the interventions that may affect the sperm DNA fragmentation, such as lifestyle modifications, smoking cessation, weight loss, exercise reduction, and treatment of infections, control of diabetes, treatment of varicocele, antioxidant therapies, sperm selection. All these modalities are available, but there are limited studies in evaluating that whether these interventions will be beneficial or not. So this is the reason that sperm DNA testing is not required, although it increases the risk of miscarriage. All right. Now coming to the lifestyle, what we are going to tell the patient, and it is also very important for MRCOG Part-3 exam as well, because in communication part, we are going to discuss the patient that what factors can reduce her risk. And in this particular guideline, they have placed quite emphasis on the lifestyle modifications. In that particular guideline, they have mentioned that BMI should be 19 to 25, limited intake of alcohol and caffeine cessation. Caffeine amount now has been recommended that is less than 200 milligram. right? Limited alcohol, smoking, and caffeine. Caffeine should be less than 200 milligrams per day. And then, yes, here comes your all the single your EMQs, acquired thrombophilias, inherited thrombophilias, and here is the management plan that you are going to make in the MRCOG Part 3 SPTs, right? This is the management plan that you are going to discuss. This is the most important line, and this is the most important slide. In the women where the diagnosis of antiphospholipid syndrome has been made, in those women we are going to plan their management, because management is available. It is a very important figure, and it's the frequently coming question that this treatment will reduce the risk of miscarriage rate by 54%. It is a must exam question, and you must remember this figure as well. I have included very less figures in this guideline so that to make it easier for you guys and to remember that which figures are most important, because I will mention a lot of figures, many digits and figures have been mentioned in this guideline, but it is very difficult to remember all those. So I have mentioned very less so that you will be knowing that what are the most important. This is the most important figure. One is the slide about the age risks that I have mentioned, and one is this. This treatment reduces the miscarriage rate by 54%. This is a must exam question. So what we are going to recommend, acquired thrombophilias, and what this guideline recommend about the women who are diagnosed with antiphospholipid syndrome. Aspirin, 75 milligram, and heparin, enoxaparin, 40 milligram subcutaneously. And remember that when we have to start this and when we have to end this, right? We have to start this from when the urine pregnancy test will become positive, and then we will continue this until 34 weeks of gestation, right? There was previously there was a great ambiguity, and there was a lot of queries about that when we have to start and when we have to stop this, but now it is pretty clear that we have to start this from the risk of when the urine pregnancy test will become positive until 34 weeks of gestation. We will continue, right? Because this treatment is going to reduce the risk of miscarriage by 54%. Okay. So now what is next is inherited thrombophilia. As I have mentioned that the risk association with inherited thrombophilia and recurrent miscarriage is quite weak. So this is the reason that routine treatment is not recommended. Routine treatment is not recommended. Individualized treatment can be considered based on the risk of maternal thrombosis or the previous placental thrombosis. What does it mean? Let me clear this, guys. Actually, routine treatment is not recommended because of lack of evidence. So what in the exam we are going to choose? In the exam, we are not going to pick the treatment option, right? For the MRCOG Part 2 students. But for the Part 3 students? Part 3 students will say that yes, treatment routine is not recommended, but they are going to assess the risk of the patient in terms of maternal thrombosis and in terms of previous placental thrombosis, and then their multidisciplinary team or their consultants are going to decide depending upon their individual situation that whether the treatment is required or not. And for the maternal thrombosis, they will take the treatment that is according to the Green Top guideline of venous thromboembolism, their prevention, their prophylaxis doses, and their therapeutic doses. So they will be taking the treatments according to that, right? But not for the recurrent miscarriage. Okay, now genetic factors, right? Patients who have been diagnosed with the genetic factors, what treatment we can offer and what options we can offer to them. Patients who are having genetic factor diagnosed, what does it mean? That we have sent the cytogenetic analysis, parental karyotyping has been done, or any genetic factor has been diagnosed. We have to give 3 options to the patient. This is another scenario for the Part 3 exam, and this is the figures and these are the numbers for the Part 2 candidates. These are very important. We can give them 3 options. We can tell them you can go ahead for the natural conception, right? You do not need any treatment. Or they can go for the IVF, right? Pre-implantation genetic diagnosis, they can go for that. And for selective, because the cumulative live birth rate is 65% if they go for the IVF. And they can go for the cumulative, and the cumulative live birth rate for the natural conception is 67%. So you guys, can you see that these are very close figures, 67 and 65? So there is no such difference. With the natural conception, they have a very good and very high live birth rate. So why to go for the IVF treatment and for the fertility centers? And the gamete donation is another option, but we have to give all these options to the patient. and then we can make a well-informed decision and they can make a choice, right? But the natural conception rate is also, although very high in these patients. Then comes the anatomical factors. Actually, as I have already mentioned, that in acquired anatomical defects, hysteroscopic resection of the uterine septum in the research context only. It means it is not recommended. Whenever there is written that it's in a research context only, then you have to tick only in this case. Otherwise, routinely for all the patients, hysteroscopic resection of the uterine septum is not recommended. And the choice of hysteroscopic myomectomy versus expectant is individualized. This is what is recommended in this guideline. And this is a very, very important slide because many EMQs will be made from this guideline, from this particular topic, and because this is the new thing that they have added. Mark my words that this is coming in your exam. This is the part of your exam. I am telling it again and again that this is the new thing, that this is definitely going to come, and any exam station can also be from this particular slide. Because you have to remember all these 4 or 5 points that I have mentioned. I have made these key points so that you do not need to dig the guideline that what is important, what is the exactly recommended. Because you know that there is many controversial points in this guideline as well. Difference of opinion is also there. But I have summarized all this for you to make it easier, super easy for you and super easy to remember as well. So what we are going to do, as I have already mentioned, that women who are having history of recurrent miscarriages and thyroid peroxidase antibodies positive, but they are euthyroid. It means you have done their TFT, thyroid T3, T4, the levels are normal, but antibodies are only positive. Only one thing is coming, that is antibodies are positive and they are having history of recurrent miscarriage. Thyroxine is not recommended. It means treatment is not recommended. What you're going to treat, her thyroid levels are normal, but she's only having antibodies positive. It means you're not going to treat this patient. Okay. Then comes the other point. Patients who are having moderate subclinical hypothyroidism and mild subclinical hypothyroidism. Let me tell you that what is mild and what is moderate. Mild, everyone knows that mild subclinical hypothyroidism means that hypothyroidism is there, but it is mild. The TSH, as the TSH value becomes more high and high, it will become severe hypothyroidism. So TSH value is more than 2.5, but it is less than 4. It means it is mild subclinical hypothyroidism, right? TSH value is more than 2.5, but it is less than 4. It means that thyroxine supplementation is not recommended. You are not going to treat. These two patients, you are not going to treat them. Patients with recurrent miscarriages, thyroid peroxidase antibodies, but she's euthyroid. You're not going to treat. Patient with a mild subclinical hypothyroidism, just check the levels in your EMQs. Just check the level in your scenario. That patient is having levels of more than 2.5 but less than 4, right? If it is less than 4, you are not going to give any treatment. But if she's having moderate subclinical hypothyroidism, that TSH is more than 4, then you have to give the thyroid supplementation to this patient. It can be considered. This is a very important line that has mentioned in this guideline. Now, after the diagnosis and after we have started the treatment, or even if we have not started the treatment, we have started the treatment only in this scenario. These 3 scenarios will be coming. But where you will start the treatment? Only in this scenario. What you're going to do in this scenario. Now, you have diagnosed this, you have started the treatment as well. How you are going to monitor the patient now? Women with the thyroid peroxidase antibodies and or subclinical hypothyroidism in pregnancy, any of this scenario, whether antibodies positive, whether subclinical hypothyroidism, whatever the scenario is, you are going to do regular TSH measurement. When she is pregnant, you are going to do the regular TSH measurement. 7 to 9 weeks of pregnancy, you will start, and then you will do the regular monitoring of until 34 weeks of gestation. Not after 34. And what does the regular means? Regular means that it depends upon her levels. It depends upon the decision of multidisciplinary team. It can be 1 or 2 weekly, right? So that is usually in the guidelines what the regular means. It will be started from 7 to 9 weeks. Remember, 7 to 9 weeks, it is a single best answer question that when it will be started, whether it will be started from UPT positive, whether it will be started from 12 weeks. Remember, friends, that it will be started from 7 to 9 weeks. And then regularly levels will be monitored until 34 weeks. In case of thyroid peroxidase, euthyroid antibody status. Now here is a difference. When this is the scenario, now comes this scenario. In case of TPO antibodies positive, but patient is euthyroid, right? This we are discussing, this monitoring schedule is for the patient who is having subclinical hypothyroidism in pregnancy. They have another monitoring schedule. They will be starting from 7 to 9 weeks and they will be doing regular monitoring until 34 weeks. But in case of TPO antibody status positive, but patient is euthyroid, not subclinical hypothyroidism, in that case, you will measure TSH from 7 to 9 weeks. Starting time period is same, 7 to 9 weeks. But here in each subsequent trimester, here you will monitor at every trimester, first trimester, second trimester and third trimester, because there is a risk of progression to the hypothyroidism. Patient is already having antibodies. At any time, she can become hypothyroid. This is the reason you are going to measure the levels in every trimester, right? This is the treatment of the endocrine factors, and as I have told you that many EMQs can come from this part. Now the progesterone supplementation. Actually, there is also in the previous guideline, the progesterone supplementation was not mentioned. This is the new in this guideline that we have. Now we have the option that we can give the patient progesterone supplements as well. They will actually give you the scenario that some patient is here with you with complaint of vaginal bleeding, and what you are going to choose for the patient. Now, what you are going to choose for this patient? Progesterone supplementation. Women with a recurrent miscarriage with early pregnancy bleed, you are going to choose 400 milligram micronized progesterone, and remember that this is a vaginal route. Guideline has the recommendation of the guideline is the vaginal route, right? And this is the 400 microgram twice daily. 2 times a day you are going to give 400 milligram micronized progesterone, and it is starting from the time of bleeding, like she came to you at 12 weeks or 10 weeks. So starting from the time of bleeding until 16 weeks of the gestation, you will continue this micronized progesterone till 16 weeks. This is a single best answer question, friends. Mark my word, this is a very important, because all these recommendations are new. So it is very important to memorize these points. Women with unexplained recurrent miscarriage, progesterone supplementation should be used with caution, and it's not going to improve the outcome, right? So this is a very important thing that they have mentioned, that progesterone supplementation is not going to improve unexplained miscarriages, right? How we are going to manage unexplained miscarriage? Actually, there is a very good and very important thing that is for the patients who are having recurrent miscarriages, and that is the recurrent miscarriages clinic. So patients with the unexplained miscarriage, they will be referred. Their referral will be towards the recurrent miscarriage clinics, and where they will be offered supportive care. Supportive care, tender, loving care is the word that is used in the TOG article as well. So the supportive care is the word that you have to choose for this question when the unexplained miscarriage will be given. Whenever the scenario of unexplained miscarriage, what you're going to choose, you're not going to give heparin, aspirin, thyroxine, nothing will be given for this patient, right? Whenever there is unexplained miscarriage, you are going to choose supportive care only, because successful pregnancy outcome with the supportive care is 75%. This is another exam question, and this is a frequently coming percentage. This is a very, very important percentage. So this is the management of recurrent unexplained miscarriage. Actually, after discussing the miscarriage, this guideline has made some recommendations for the next pregnancy as well, that we will send the patient plan with one doctor, and the doctor who are expert in dealing with the patients who are having recurrent miscarriages, definitely they having all the knowledge about her previous history. They will be very empathetic approach. They will be referring for the emotional needs, psychological, social, any help that patient will be needing, that will be provided to her, because social support, psychological support, and the counselors are very, very important for these patients. They need very empathy, and a lot of support will be provided to them, so that in the next pregnancy a healthy outcome can be awaited. Their regular ultrasounds will be done, and their after urine pregnancy test, their ultrasound will be done, and they will be checked every 2 weeks. When their urine pregnancy test will be positive, their checkups and their regular visits with early pregnancy miscarriage clinics will be done every 2 weeks, right? And in case again an unfortunate event happened, in miscarriage happened, then definitely a lot of psychological support, lot of social support, counselor, trained professional counselor support, and midwifery support, a lot of help will be needed, and that will be provided for these patients. So this is all about this guideline, friends, that I have discussed with you, and I hope that I could make it clear to you. Many important points that I have been discussed in these slides: endocrine factors, genetic factors, progesterone, the new recommendations about the progesterone, about the thyroid. This was very important. Please have a look at it again and listen to this guideline again and mark these points in your guidelines as well, so that next time if you are reading it, you will have a fair good idea that how you have to read this guideline. I have tried to make it pretty simple for you and hope that this will be beneficial for you. So I will be again with you with any other important guideline so that we can discuss the important and new guidelines. So best of luck and happy studying. Thank you so much. Thank you for your time for listening.